Hi there, greetings and welcome to another video on surgical discussion. The statistics presented here can help you to make a scientific judgment when a patient asks you a question, or else when you are faced with a certain situation either in the ICU or especially in the elderly population. It is wise to know that about 10 to 20% of the general population can develop gallstones at some stage of life. They usually tend to have newer gallstones as the age increases. So after the age of 50, you can expect more amount of people to have gallstones, whereas the younger population would have 10%, the older population would have roughly about 20%. Now, of this 20% of the population which has gallstones, 80% of them remain silent and absolutely asymptomatic. Usually, about 1 to 4% of this 20% would develop signs and symptoms annually, and when they usually develop signs, symptoms and complications, it is usually because of a stone which is impacted in the CBD or a stone which has passed off via natural into the CBD, giving them a transient obstructive jaundice which needs to be dealt with. 10% of this population would have symptoms within 5 years of diagnosis, and it slowly rises to about 20% in 20 years. So if you look at it from a perspective, 1 out of 10 patients will develop symptoms within 5 years of diagnosis. So if you do an ultrasound for about 100 people, 1 in 10 would have symptoms within 5 years. And if you leave them like that, maybe about 1 in 5 or else 2 in 10 would have symptoms in about 20 years. So is it justified to actually take all these patients and put them under the knife when you have only 1 in 10 who are going to get symptomatic? Now the choice is yours. Remember that there is no relationship of the stone, the size, the type and the thickness of the gallbladder wall which acts as a predictor to tell you who could have symptoms later and who could have complications later. There is no relationship at all. Usually if a stone is more than 2.5 cm in size, it could have higher rates of having acute cholecystitis or carcinoma of the gallbladder. There is a higher risk of carcinoma of the gallbladder in a porcine gallbladder and in polyps which are more than 10 to 15 millimeters in size. Now the question about doing a prophylactic cholecystectomy. This means that a patient comes to you in the clinic and he says that I have been diagnosed with gallstones by ultrasound, and should I undergo a prophylactic cholecystectomy because I'm afraid that in the future I could have symptoms. Now you know your statistics that 1 in 10 in the first 5 years and maybe 2 in 10 in the next 20 years could actually develop symptoms. So is it really necessary for you to go and knock off his gallbladder? Think again. Now the availability of laparoscopic cholecystectomy means to say that the morbidity and mortality of the operation is very low. But this should not expand the indication of cholecystectomy. One used to believe earlier that patients who are diabetic used to have diabetic dysautonomia, and when they used to have stasis, even the pain used to be masked. So it is better to do an laparoscopic cholecystectomy in a diabetic. Actually, it is not indicated because there is no significant difference of an incidence in acute cholecystitis either in the diabetic or non-diabetic. Second of all, about 30 to 40% of patients who are post-transplant, either on cyclosporin or tacrolimus, develop stones because these drugs are pro-lithogenic. So it is advisable for these patients to undergo a cholecystectomy. 42% of heart transplant patients develop stones. Again, it's because of the drugs, and these deserve a cholecystectomy. Patients who are having sickle cell anemia, you could have a crisis, and laparoscopic cholecystectomy is done to prevent the confusion in diagnosing the crisis. As far as hereditary spherocytosis is concerned, incidental cholecystectomy is done during the splenectomy. This is done because anyway the abdomen is being opened, And when you know that there is a likely event of gallstones coming later, and probably even having gallstones in the operation, rather knock it off because you get an opportunity to do so. Cirrhotic and non-cirrhotic patients have the same incidence of getting acute cholecystitis in the presence of gallstones. Therefore, it doesn't make any sense to take up these patients for an emergency laparoscopic cholecystectomy unless indicated. Doing an elective cholecystectomy may not be a good idea because these people may not be able to handle the anesthetic drugs, and also they may not be able to excrete them so well. It is safer to go in for an expectant management or a conservative management for cirrhotic patients. Patients on TPM, usually 35% of them develop gallstones and 40% of them need an emergency laparoscopic cholecystectomy, having an operative morbidity of 54% and a mortality of 11%. Considering these statistics, it is safer to perform a laparoscopic cholecystectomy on patients who are undergoing TPN, especially if they have been diagnosed ultrasonically with gallbladder stones. After bariatric surgery, 40% of patients develop gallstones in 6 months. So it is best to perform a lap chole during the bariatric procedure if there are stones. Whereas if there are no stones, the patients can actually be given drugs to prevent the formation of stones. But then again, these drugs are not available in all countries. So rather stick to a policy of saying that if one has gallstones, it's best to knock off the gallbladder during the bariatric procedure. Many surgeons don't want to do such kind of a thing because they feel you're opening two different cavities in the bowel. They're also afraid that in the presence of a lot of fat in the obese patients, the anatomy of the Carrow's triangle would not be clearly visualized. Therefore, not only would you have a complication of the gallbladder tree and also the biliary tree, you could also have complications of the sleeve or complications of the bypass, which would then compound the problems in the other system. So many of them think it's safer to wait for a while, maybe a year or two after the procedure, when there is a lot of excess body weight loss, and then embark upon the gallstone disease. It's the decision of the surgeon and the patient, and both of them get together and they negotiate a plan of action, after which they embark upon the bariatric surgery. Now to discuss the indications for a prophylactic cholecystectomy. This is when somebody doesn't have any signs and symptoms, but they are having gallbladder stones. It is to be done if the life expectancy is more than 20 years. Why this figure? Because you know that about 10% of them would get symptomatic in 20 years. So you're afraid that your patient may be of this 10%, go ahead and knock off the gallbladder. If the gallstone is more than 2 cm in diameter, there is a high chance that they could develop a gallbladder cancer, although it's a very small percentage. If the calculus is more than 3 mm and the cystic duct is patent, there is a likelihood that the stone could pass into the cystic duct, into the CBD, causing obstructive jaundice, and you don't want your patient to have this complication. Radio-opaque calculi, because there is more incidence of cholecystitis with radio-opaque calculi. If there are polyps more than 15 millimeters, go ahead and do a lap chole. If there is a non-functioning or a calcified gallbladder, such as a porcelain gallbladder, one should go ahead and do it because there is more chance of CA gallbladder. But remember that any gallbladder which has gallstones is a non-functioning gallbladder. That is one of the reasons when there is stasis and dyskinesia where one develops a gallstone. So you can always tell your patients that you are having a gallstone because your gallbladder is non-functional, and even if you take off your gallbladder which is having a gallstone, there is not going to be any difference because as it is, that portion is non-functional. Or else even if it functions optimally. It gives you more of pathology as opposed to physiology. Women who are less than 60 years of age make sense because there is more of estrogen in the system, and this could be lithogenic. So you could have further stones to be added upon when they are already having stones. In an area which is having a high prevalence of gallbladder cancer, it is safer to knock off the gallbladder as opposed to your patient's developing complications because of carcinoma. You open up a patient and during a laparotomy, you find the gallbladder having stones. And now you want to take off the gallbladder for an indication which is not acute cholecystitis or chronic cholecystitis. That is called an incidental cholecystectomy. So you can do an incidental cholecystectomy if the gallbladder has stones and there is evidence of chronic cholecystitis. What is the evidence of chronic cholecystitis? The same things that we discussed earlier regarding the shape, the size, and the thickness of the gallbladder. Second of all, it is done if the patient is more than 70 years of age, because you get a small window of opportunity inside the abdomen. So rather go and knock it off. As far as the patients who are more than 70 years of age, one should know a statistic. Now, if a patient who is more than 70 years of age presents to you with obstructive jaundice, and you do an ERCP now, and you take off the CBD stones, only 15% of this population would have a recurrent obstructive jaundice, or they would have recurrent symptoms of acute or chronic cholecystitis. So therefore, an ERCP with a clearance of the CBD stones is a good enough treatment for a patient over 70 years of age. If they have a recurrence of symptoms, either obstructive jaundice or cholecystitis, that is when one can plan to do a laparoscopic cholecystectomy, or else the treatment that is indicated in most of the cases is just a simple ERCP, and then you can follow up the patient and do a conservative management. Certain conditions predispose to the development of gallstones. Obesity and pregnancy, and certain dietary factors which promote the consumption of fat. Crohn's disease because of the relative malabsorption. Terminal ileal disease because of the dysfunction in the enterohepatic circulation. Any hemolytic disease which causes more amount of a biliary load on the liver, and gastric surgery because usually it is associated with the vagotomy, which leads to a relaxation of the gallbladder. Now one should understand the statistics behind gallbladder disease, especially the stones. The statistics which I presented earlier were the American statistics. The European statistics are as follows. Anywhere from 11 to 36% of the population would have gallbladder stones. Of this 11 to 36%, only 3% have actually symptoms. 5% of this 3% will have complications of gallbladder stones. So there is no strong indication to knock off every gallbladder which is having stones. And as you can see the table that is displayed here, 1 to 2% of people who are asymptomatic will have biliary colic, and only 0.2% per year of the asymptomatic population would have acute cholecystitis. And people would have a range from acute cholecystitis to biliary colic, chronic cholecystitis, etc., CBD stones at the rate of 5% per year. Now the incidence of gallbladder CA in symptomatic patients is 0.08%. So this being the case, one is justified in not doing a laparoscopic cholecystectomy for every patient who has been diagnosed with gallstones. We also discussed earlier about prophylactic cholecystectomy. Here I would like to put in a word. If your patient is living in an area where there is no medical care, or he is very far off, for example, certain people posted in the military or other people, I'm not talking about astronauts, I'm saying people who are in villages, or they may be in areas which are away from the city. And if they prefer to have a lap chole, I think they can merit the benefit of this operation, as opposed to coming in an emergency crash situation. Rather knock things off when everything is under control. The symptomatology of gallbladder stones. Please remember that 85 to sometimes even 90% of your patients are absolutely asymptomatic. If they have symptoms, it depends upon the location of the stone. If the stones are in the gallbladder, they could suffer from biliary colic, acute or chronic cholecystitis. If the stone blocks the cystic duct, either they could have an empyema, which means pus in a preformed anatomical space, or they could have a mucocele if the bile gets completely absorbed and there is only mucus inside the gallbladder. Yes, rarely the gallbladder can perforate, and the mechanisms have been explained in the previous video. If the gallstone is inside the gallbladder or the bile ducts and it perforates, either it can perforate into the free peritoneal cavity or it could fistulate either into the duodenum or into the colon. Yes, at times it could even happen that it perforates into the bowel. If the gallbladder is in the bile ducts, there could be biliary obstruction with acute cholangitis or acute pancreatitis. The stone in the intestine would cause a tumbling obstruction, and this is called a gallstone ileus. What exactly do you do to treat a patient in these circumstances? If it's an asymptomatic gallbladder, we have discussed this earlier. If it's acute cholecystitis and chronic cholecystitis, knock off the gallbladder. Empyema of the gallbladder is a scary situation, and most of the time one should go in for a tube cholecystostomy or just a cholecystostomy in the acute phase, and then progress on to a laparoscopic cholecystectomy when the patient is fit. In cases of mucocele, go ahead with the lap chole. In cases of perforation, when the patient presents to you with either bowel obstruction because of the stone, or if he presents with some degree of GI bleeding, one needs to go in and just take the stone from the intestine so that there is no more obstruction. In the acute phase, do not try to dismantle the fistula and don't try to do anything at that area because it is highly inflamed and chances are that you will end up with a lot of complications. When the stones are in the biliary ducts, when there is a biliary obstruction, you need to relieve the obstruction by whatever means, because the mechanical obstruction of the bile tract would lead to cholangitis. So you need to cause biliary decompression by any means, either it is an ERCP or a PTC. When the stone is in the intestine, we already discussed, the thing that you need to do is take off the stone from the lumen of the intestine. In chronic cholecystitis, there is usually a stone obstructing the cystic duct. This leads to distension of the gallbladder and contraction of the gallbladder wall from the fundus. There are recurrent attacks of pain. This is called as biliary colic. The mucosa gets pushed through the muscle coat to form multiple small sinuses called Aschoff-Rokitansky sinuses. In chronic cholecystitis, the pain can last for about 1 to 5 hours, severe for about half an hour or 1 hour or so. The pain is severe, occurs at the upper right quadrant, and it is precipitated by a fatty meal. As opposed to this, in acute cholecystitis, there is a chemical inflammation of the gallbladder which is caused because of the presence of lysolecithin, which acts like a soap or a surface active agent. It takes away all the mucus and exposes the mucosa to the surfactant action of the bile. Once the mucosa gets stripped of itself, that is when the bile and the bacteria directly act on the submucosa, and herein there is infiltration of the wall, breaking up of the extracellular matrix, and this can lead to empyema, emphysematous gallbladder, perforation of the gallbladder, ischemia, and various other clinical consequences. At times, if there is a complete impaction of a stone into the cystic duct, that is when one can have a hydrops of the gallbladder, presenting as a huge, large distended gallbladder with clear bile. People do have attacks of chronic cholecystitis in a case of hydrops, but it never nearly presents as acute cholecystitis. The treatment for acute cholecystitis, or even acute on top of chronic cholecystitis, is laparoscopic cholecystectomy. It is the gold standard surgical procedure nowadays. The antibiotic cover that should be given should be a third generation cephalosporin with metronidazole. This is to cover the gram-negative aerobes and the anaerobic organisms. 50% of the cases would have sterile bile in the gallbladder, but it is always good to give a prophylactic antibiotic because one never knows which patient has infection and which patient doesn't. After an acute attack, it is advisable to go in for an operation within 72 hours of the initial attack. If one is not able to get into the OR within this window period, then one can get operated within 6 to 8 weeks after the attack. It does happen that 20% of the people who have been asked to come back after 6 weeks can come back with recurrent symptoms and they have to be operated initially. Either in the acute setting or people who are having chronic cholecystitis can have a conversion rate from 10 to 15% from lap to open. One should bear in mind that if patients are unfit and they have acute cholecystitis or maybe even a consequence of empyema, they can actually undergo cholecystostomy, in which a tube has been placed in the gallbladder. It can be done either through intervention or as an open procedure. Stones can be extracted from the gallbladder using this tube, and the tube can be taken off once a cholangiography is done and it shows that the cystic duct is patent. Laparoscopic cholecystectomy can then be scheduled in the near future. Around 6 to 12% of people who have gallstones can also have associated stones in the CBD, known as Choledocholithiasis. The vast majority of stones in the Western countries are called secondary stones because they form in the gallbladder and then they migrate into the CBD. Whereas in the Asian population, it is mainly a primary stone which forms primarily in the CBD. The primary stones are usually brown or black pigment variety, whereas the secondary stones are usually the cholesterol variety. Clinically, a patient with CBD stones would present with obstructive jaundice. It could be either a partial or complete obstruction, cholangitis, pancreatitis, or if the stone passes through the duct and it happens to be very large, it could even cause a gallstone ileus, although it is very rare for small stones to cause the ileus. Biochemically, there would be elevated ALT and total bilirubin and direct bilirubin. At times, the transaminases also could be elevated because of the cholestasis. An ultrasound would show a dilated CBD. In the presence of gallstones, a dilated CBD and jaundice and biliary pain, one should think of CBD stones. ERCP is the gold standard treatment for the CBD stones, and once the stones are swept away, it's time to do laparoscopic cholecystectomy in the same admission if the patient improves biochemically and clinically. Usually, in addition to doing the ERCP, one should also keep in mind that in the likely event of failure, the biliary system needs to be drained. It can either be done by a PTC or one should actually go in for an operative approach by doing an open cholecystectomy with a CBD exploration. So it goes on that after the treatment, either laparoscopic or open exploration of the CBD, or if one goes in for the ERCP, if the stones have been completely cleared during the time of OR, the job is done. If stones were not found in the OR, but there were some stones in situ, these stones are called retained stones. It can also happen that the stones could recur because of the primary pathology being untreated. In either case, one needs to do an ERCP again. An intraoperative cholangiogram at the time of cholecystectomy also can document the presence or absence of a stone. If one does an open exploration, it is better to keep the T-tube in situ so that the CBD heals well. If one is not able to do so, then the other option is either a choledochoduodenostomy or a Roux-en-Y choledochojejunectomy. Tricky situations are wherein there are patients who are old, above 65 or 70 years of age, who present with CBD stones and gallstones. One mainly needs to do the ERCP to clear the CBD so that complications such as cholangitis are prevented. Once the CBD is cleared, it's only about 15% of patients who will actually have recurrent attacks of cholangitis or CBD stones from the GB stones. Therefore, it is not necessary to subject every patient of CBD stones in the elderly age group for a laparoscopic cholecystectomy following the ERCP. Cholangitis may be caused because of biliary obstruction either by a stone, tumor, parasites or indwelling stents, or sometimes even instrumentation. One should remember that it is not only the bacterial contamination which is responsible for cholangitis, but it is in addition with a biliary stasis. The common organisms cultured are Klebsiella, E. coli, Enterobacter, bacteroids, and Streptococcus faecalis. When there is cholangitis, clinically they could be either a Charcot's triad or a Raynaud's pentad. The treatment for these conditions are immediate biliary drainage. It's always advisable, yes, to add antibiotics, to give IV fluids, to maintain the hydration, to admit the patient in ICU if required. But if one doesn't go on to proceed with the biliary drainage, situations can become worse. It's always important to drain the biliary system either by the ERCP, and if it fails, to go in for a PTC. If supposing these two procedures don't work or they fail, it's time to go in for an operative approach. Tube cholecystostomy, if feasible and if it works, is a good option, but if it fails, one should go in for an immediate CBD exploration with a decompressive T-tube placement. It's life-saving in certain circumstances. Definitive surgery can always be deferred until the cholangitis has completely been treated and the cause has been clearly established. Acute cholangitis is associated with an overall mortality of around 5%, especially when it's associated with renal failure, cardiac impairment, hepatic abscesses, malignancies. Cholangiohepatitis is a condition which is usually seen in the Orient. There are repeated attacks of cholangitis which also gets the liver involved due to infection. It involves both the intra and the extrahepatic biliary tree, and sometimes because of this repeated attack there is fibrosis of the bile ducts. This causes further attacks, stone formation, and sometimes complete destruction of the liver parenchyma because of repeated abscesses and fibrosis. The treatment: treat the cause, and one may also need to treat the damaging complications. Parts of liver resection may need to be done. Roux-en-Y hepatocoagulopathy may also be necessitated. A cholecystostomy is a simple procedure, either done by the interventional radiology, in which a guide wire having a pigtail is passed into the liver parenchyma through the skin. It enters the gall bladder and it is left there in situ. Once the guide wire is withdrawn, the pigtail coils inside the gall bladder. The advantage of passing the pigtail through the liver parenchyma is that there is no peritubal leak of bile, and once the tube is pulled out, Even if there is a bile leak, it leaks into the liver. Third advantage is that there is no free drainage of bile into the peritoneum in the likely event of the tube getting dislodged. This procedure can even be done openly, and if one wants to remove the tube, you have to perform a cholangiogram to see whether the bile freely flows or the dye freely flows into the cystic duct. Later, one can either go in for an open or a laparoscopic cholecystectomy. A cholecystectomy can be done either open or laparoscopic. The classical method is to start at the junction of the infundibulum and the cystic duct, that is the neck region. From there, take off the peritoneum of the Caros triangle, clip the cystic duct and the artery separately, and then take off the gallbladder from the gallbladder fossa. If the reverse is done, wherein one starts in from the fundus and then goes all the way to the junction of the neck and cystic duct, that is called the fundus first method. It may not be the best idea in the world because stones can actually slip into the cystic duct, into the CBD, and later either you have to do an on-table exploration or, as is commonly done nowadays, an ERCP. So you end up doing two procedures instead of one. I am talking very briefly on this because there is going to be a separate video on operative approaches. Subtotal cholecystectomy also is another option where there is too much of difficulty to trace the anatomy or too much of difficulty to tackle the Caros triangle. This also should be discussed in the separate video. Acalculous cholecystitis typically develops in critically ill patients who are in the ICU. It can happen to patients who are on TPN, extensive burns, sepsis, major operative procedures, multiple traumas, prolonged illnesses, and those who are having multiple organ dysfunction syndrome. What usually happens in acute acalculous cholecystitis is that the gallbladder gets distended, there is bile stasis and ischemia. Now, the treatment for the acute acalculous cholecystitis is an emergency decompression of the gallbladder. The decompression will then lead to a better perfusion, and hopefully there should be no necrosis. But in the likely event that fails, one may need to go in for an operative approach. But these patients are usually unfit for a surgical procedure, and in most cases, a percutaneous or an open cholecystostomy do the trick. Biliary cysts can occur in 1 every 100,000 to 1 every 150,000 population, more commonly seen in females and more commonly seen in the population of the eastern countries. Usually there is an anatomical derangement in which the CBD opens into the pancreatic duct and the pancreatic enzymes freely flow into the CBD, thereby increasing the pressure, and the enzymes of the pancreas act on the CBD to render it weak. The classification of the biliary cysts are 1 to 5. Type 1 is a fusiform dilatation and type 2 is a saccular dilatation of the extrahepatic biliary tree. Type 3 is a choledococele. Type 4 involves both the intra and extrahepatic tree having multiple cysts, whereas type 4b involves mainly extrahepatic cysts. Type 5 is also known as Caroli's disease, in which there are multiple intrahepatic biliary cysts. The treatment for type 1, type 2 and type 4 involves complete excision of the extrahepatic biliary tree with cholecystectomy, followed by a bilioenteric anastomosis in the form of a hepatocholecystectomy, Roux-en-Y. In case of type 3, wherein it is a choledococele, the only thing required to do is a good sphincterotomy, and that leads to good drainage. Type 5, Caroli's disease, if it involves only one lobe, one can go in for a unilateral lobectomy, whereas if it involves both lobes, it is best to consider a rebel transplant. Sclerosing cholangitis is a condition which is seen wherein there are repeated attacks of fibrosis of the bile ducts, thereby leading to strictures, obstructive jaundice, and liver cell failure because of multiple derangements which occur of the liver function over time. Primary cholangitis can occur, or primary sclerosing cholangitis occurs in autoimmune diseases, whereas secondary sclerosing cholangitis can occur because of previous biliary surgery, toxic agents, drugs, bile duct stones, or many attacks of acute cholangitis. Usually in sclerosing cholangitis, slowly people develop liver failure in time, and the best option for this is either doing a stent as a temporary measure, or the best thing to do in the end would be a transplantation. Cases of stenosis of the sphincter of OD are best treated by a sphincterotomy. Bile duct injuries can occur as a complication of laparoscopic cholecystectomy. It can also occur during the operative approaches to either a sleeve gastrectomy or any operative procedure in the upper GI. The Strasberg classification is a commonly one that is followed. If there is a type A duct injury, which means to say there is a cystic duct leak or duct from a small duct from the liver bed, the treatment that is required is a simple drainage percutaneously followed by an ERCP, keeping the drain in situ. Once the drainage reduces from the tube, it can be taken off. In a type B Strasberg injury, there is usually a clipping or an occlusion of an aberrant right hepatic duct. It depends upon the clinical consequence now at hand. If after the clipping there is a very mild cholangitis or discomfort, it can be treated conservatively. Whereas if the cholangitis is severe, it requires to be drained, or else a segmental liver resection is necessary. In case of a type C injury, there is a complete transection of the aberrant duct. One can go in for an interventional radiology drainage percutaneous, and if this drain doesn't reduce by itself in a long time, then one can completely occlude the duct and follow the same treatment plan for the type B injury. A type D injury involves less than 50% transection of the extrahepatic biliary bile duct. If supposing there is a very small injury, the only thing that is required is to start by the conservative approach by doing a tube drainage and an endoscopic sphincterotomy or a stent. And if this doesn't seem to solve the problem, an operative approach to repair the bile ducts. Type E injuries involve the extrahepatic biliary tree, but here there is more than 50% transection of the duct. And one can start with the conservative management, but the ideal approach happens to be the operative intervention, wherein there is a resection of the extrahepatic biliary tree followed by a Roux-en-Y hepaticojejunostomy or a choledochojejunostomy. The consequences of hepatic duct injuries are not as simple. There could be multiple strictures that could be formed at various points of time. Either a stent placement or a balloon dilatation is required. The balloon dilatation results are less than satisfactory, and these have to be repeated. If there is a further injury of the liver and it causes liver failure, one may have to plan in for either a partial liver resection, depending on which portion is completely fibrosed and failing, or one may have to go in for a complete retransplant of the liver. 80 to 90% of the gallbladder tumors are adenocarcinomas. Other varieties are squamous cell, adenosquamous, oat cell, and anaplastic variety. The cancer of the gallbladder spreads via the lymphatics, the venous drainage, and direct invasion into the liver. It is known that the gallbladder veins drain into the liver, therefore Direct extension and venous drainage take the tumor into the segment 4 and segment 5 of the liver. The gallbladder lymphatics drains into the cystic lymph node of Lund, then into the pericholedochal and hilar lymph nodes, and finally into the peripancreatic and duodenal and periportal and celiac lymph nodes. The treatment depends upon the stage of the tumor. A T1 tumor is one which involves the mucosa and the muscularis. For a T1 lesion, which is usually proven after the biopsy, it is enough to undergo a laparoscopic cholecystectomy. But some people also prefer that if the report comes as a tumor, they would like to excise the laparoscopic port wounds. If it is a T2 tumor, that means the tumor has gone beyond the muscularis. It is necessary to excise the segment 4 and segment 5 of the liver. For lesions beyond T4 and T3, it may be necessary to excise more of the liver, something like a right hepatectomy, which is done to remove the complete tumor into the liver, which may be a microscopic metastasis. The prognosis after the GB tumor cancer excisions are poor because the patients present with multiple episodes of cholangitis, obstructive jaundice, bowel obstruction, carcinomatosis, and pain. Carcinoma of the bile duct is a very bad disease because by the time they are diagnosed, most of the time they are unresectable because they have a very late presentation. The classification of the bile duct tumor is based on the Bismuth-Corlett classification of the perihilar tumors, and in these cases it entirely depends upon the vascular involvement. If there is a Klatskin tumor and no vascular involvement, one can do with resection of the extrahepatic biliary tree with the hepatococyginostomy. If it is type 3 or type 4, wherein they are involving right and left hepatic ducts, one needs to go for separate hepatococyginostomies. If there is a distal duct involvement, the operative approach is a Whipple procedure. The prognosis of these cases post-op isn't very satisfactory because this disease usually has multiple liver metastases from the start, and they later develop other complications either because of surgery or because of the tumor itself. One must keep in mind that the cholangitis is the most dangerous complication of these tumors, and biliary tract drainage, either open or endoscopic or even intervention radiology procedures, should always be kept as treatment options for these patients. Metallic stents, balloon dilatation, endoscopic dilatation are other methods which can prove at least helpful as a bridge towards definitive therapy. Thank you so much for watching the video. If you'd like to contribute any points, or you like to edit them, or you feel that something is amiss or should be updated, either leave your comments below or send me an email. Thanks again.